Skin and soft tissue infection. So skin and soft tissue. So it includes skin, soft tissues, that is subcutaneous tissue below the skin. Multiple fascias are there, different type of, and muscles. So it excludes bones. So you can see here what the anatomy or cross section of the skin and soft tissues up to bones. Sorry, up to muscle. Connective tissue there, epidermis, dermis, here subcutaneous fat, then connective tissues including some fascia and muscles, and surrounding blood vessels, sweat glands, and blood supply and lymphatics. So epidermis, dermis, it comprises that's parts of skin. So infections are erysipelas, impetigo, folliculitis, ecthyma, furunculosis, and carbunculosis. So once infection is go beyond the skin and subcutaneous tissue, so it terms cellulitis. So if go beyond, including the fascia, subcutaneous fats, and there's blood supply, that is arteries and veins and nerves, sensitive, motor, mainly sensitive, and autonomic. Anyway, so it's termed necrotizing fasciitis. Further deep, maybe involved in skin and subcutaneous, or just confined to muscles, it's termed myonecrosis. It can be classified Clostridial and non-Clostridial. Clostridial, anaerobic bacteria. Bit of conditions, impetigo, skin. It's contagious, so it can be transmitted, and superficial infection of the skin. Mainly pathogens are Staphylococcus species, mainly aureus, and beta hemolytic streptococci such as group A, group B, even group G there. It's common in children, usually involves in the skin of the face or around mouth and nose, impetigo. Spread by direct contact, that's why terms contagious. Minor abrasions and other skin lesions predispose to this infection. Prevention is by good personal hygiene, particularly hand washing with soap. So it has two forms, non-bullous and bullous. Non-bullous mainly Streptococcus pyogenes, that is group A, stem honey crust lesions. While bullous, it is Staphylococcus aureus, the one which leads to rupture of bullae. So we can see varnish-like crust there. That's about the impetigo. We'll further discuss later on the identification of diagnosis and management. Further about skin and soft tissue infection, we classify them as purulent and non-purulent. Purulent, folliculitis, boils and abscess. While non-purulent, cellulitis, erysipelas, skin and subcutaneous tissue, necrotizing fasciitis. It's involves in the fascia as well. Folliculitis, it's a suppurative one. Infection of the superficial part of the hair follicle. So here two classification. Okay, one in anatomical, other in pathological means of classification. So don't confuse. So folliculitis, skin, superficial skin infection, superficial part of the skin. While it causes purulent, pus forming one. Ichiotent papules and pustules can be seen. You can see pustules nicely. Staphylococcus aureus, the one which causes mainly. So it's small pustules often pierced by a hair. You can see here. Legs, face, so it's a main. Psychosis barbari in the beard area. Common in humid climates and when occlusive clothes are worn. Extensive itchy folliculitis in HIV infection also there. It's a broad, all over their body, not like confined. Boils, another purulent infection term furuncles. Staphylococcus aureus is the one which cause and deeper part of the hair follicles. It go further deep. Most common on the face, neck, armpit, buttocks, and thighs. On central face, danger of cavernous sinus thrombosis. I think you know about the danger area. So if it is infection is in that particular area there, it can drain up to the cavernous sinus and leads to cavernous sinus thrombosis. It's a terrible condition. Here, furuncle, red, tender, cone-shaped swelling, heal with scarring. Recurrences may occur. That's obvious. Exclude, need to exclude carry state. Often treatment, antibiotics. If large, we need to do excision. Carbuncle, deep step infection like furuncle of hair follicles, several adjacent infection of several adjacent hair follicles. It's larger than furuncle. Cluster of boils that form a connected area of infection. Scattered like neck, back, even thighs. In diabetes and debilitated persons, they are more prone to develop. Again, treatment, I just to put there some antibiotics and surgical incision, depends. Skin abscesses, another purulent one. Oh, cause subcutaneous, maybe skin, localized collection of pus. I think you know what is pus. That is high protein exudate, contain dineutropyl, tissue debris, plus parts of microorganisms, surrounded by granulation tissue. So there is a capsule forming. Here we can't see, when we do the histopathology, we can see the capsule in the fibrous material. So antibiotic won't reach there. So there are risk factors. History of penetrating injury, infection of hematoma could be trauma leads to hematoma formation and later it can infect. Likewise. So maybe features present cellulitis, maybe the adjacent cellulitis there. Yeah. So on soft center, feel like fluid underneath once you are doing the clinical examination. It's painful, tender. Staph aureus, the one which commonly infect in organism, poor hygiene is predisposed. IND, incision and drainage is a treatment followed by oral or depending on, go with the parenteral antibiotics. Ecthyma, another, by streptococcus and also staphylococcus. Ulcer forms under the crusted surface of the infection, heals with scarring. Cellulitis, it's non-purulent. Infection in normal skin flora of exogenous bacteria, mainly Staph aureus, also beta hemolytic streptococci. Deeper skin of subcutaneous layer. Infection and inflammation and skin and subcutaneous tissue. History of trauma and ulceration may be there, maybe micro trauma there. Organism enter to the breach of the skin. This skin normal flora. It's once in the skin, they are non-pathogenic, but once they reach kind of by inoculation through kind of this breach, some of it now it's in a favorable condition and it leads to infection and inflammation. And later can spread to bloodstream, leads to bacteremia, septicemia. It's a deadly condition. There are, it can involve lower leg, hand, nose, periorbital, likewise facial cellulitis there. Clinical features, acute localized pain is there. Lymphadenitis can see. Hot, painful erythema is streaking. Painful erythematous streaking. Progressing proximally from the affected area, tracking along lymphangitis and lymphadenitis, that is lymph nodes. Maybe blisters, maybe they are plus or minus. Patient present with fever, malaise, leukocytosis if we do hematology. Erysipelas, it's like cellulitis but well demarcated. Can appreciate the margins, not like cellulitis. Okay, that's the one which we identify them as erysipelas. Streptococcus infection in the dermis, but staphylococcus also possible. Here, painful erythematous, indurated plaques, blisters, and ulceration, with or without. So, patient present with abrupt fever with chills, face, legs can happen. Common in very young, old, debilitated patients. Lymphadenomatous, erysipelas, and cellulitis overlap often. Penicillin, we can say the treatment may be different. Necrotizing fasciitis, one much fatal variety. It's a surgical emergency. It affects skin, subcutaneous fat, and fascia. So polymicrobial infection of the fascia. That's why necrotizing fasciitis. There are, we just say types 1 and type 2, but you don't want to know much. So type 1 will say E. coli, Pseudomonas, Proteus, Bacteroides, Clostridium, while type 2 mainly Streptococcus. may proceed rapidly to underlying muscles. So it leads to pyomyositis. Diagnosis is often delayed. That's how they present. Primarily a clinical diagnosis, rapid progression to septic shock, mortality is high, 30 to 50%. It's a surgical emergency. So you can see necrotizing fascia, skin fat, fascia and muscular tissues is there. Skin change is there, medial aspect of the view. Same. Clinical features: severe pain at the site of initial infection, tissue necrosis, spread in erythema, pains of tissue crepitus. Infection tracks rapidly along the tissue planes, fever, patient present with tachycardia, features of systemic inflammatory response syndrome. Diagnosis clinical, but can do imaging AI in the tissues by CT scan. But not often we offer CT scan, but patient comes with necrotizing fasciitis, we may. So it's a surgical emergency. We have to do fasciotomy to release the fascia to reduce the pressure. Otherwise, it leads to compartment syndrome. So meanwhile, we often offer with surgical team extensive debridement of maybe offer ultimately, if necessary, amputation. It depends. Bit of other infection, staphylococcus scalded skin syndrome, 4S. Here, exfoliative or epidermolytic toxin mediated disease, superantigen mediated, rapidly spreading tender erythema, dermonecrosis, outer layer of the epidermis peel off. That's scalded skin. That's a term, peel off. You can appreciate, you can see. Blistering there, writer's disease of the newborn. It's other term, most severe form of scalded skin syndrome with staphylococcus. Hyreniditis suppurativa. It's there, it in axilla and groin. So it's associated with obese patient, infection in apocrine sweat glands. Treatment is advised to reduce the weight. Oral retinoids like vitamin A, zinc gluconate may be given. Erythroderma, it's another chronic skin infection followed by Corynebacterium species. Macular ring, slightly scaly pink around the neck in its hairlines likewise. Brown or macerated white areas, armpit, groin or between toe webs. Coral pink under wood slide. If it's not done, but if earlier uh, wood slab, I think we discussed in mycology, sometime we offer. So initially maybe, not maybe, think it as a fungal infection. That's why we offer wood slab. Prevalent about diabetics, obese, and in warm climates. Topical fusidic acid is given, prescribed. Pyomyositis, another suppurative infection. Staph aureus and streptococcus infection, skeleton muscles. Pus fill abscess, pus, most common in tropical area. Myositis tropicans can affect any skeleton muscle, but common quadriceps and gluteal muscles. Patient present with fever, sepsis, localized inflammation, muscle pain, predisposing factors, immunodeficiencies, patient with intravenous drug abuse, trauma and malnutrition. There are complications like multiple abscess formation leads to sepsis, iron increase with parental antibiotics. We have to offer gangrene. There are different type of gangrene. Clinical situation where extensive tissue necrosis, complicated by bacterial infection, dry, wet, and gas. There are predisposing factors like serious injuries, leads to gangrene, ischemia due to atherosclerosis and peripheral vascular disease, diabetes, dry gangrene. The result of ischemic coagulative necrosis. There are different type of necrosis. So here we can see in extreme. So end arteries, they are black, dry, sharply demarcated. Secondary bacterial infection is insignificant. Gangrene of extremities in thromboembolic occlusion of vessels. Following infective endocarditis, it can be. Wet gangrene. Tissue necrosis is complicated by CV infection. Swollen, reddish, black, foul smelling tissues are there. Extensive liquefaction of dead tissue occurs due to invasion of organisms and acute inflammation. No clear demarcation between dead and viable tissues. Occur here also extremities and internal organs. Diabetic gangrene of foot, gangrene of bowel. That's how it goes. Gas gangrene and the varieties Clostridium myonecrosis. Other term. Clostridium perfringens is the mainly, but no okay. Septicum likewise, there are the organisms also there. Extensive tissue destruction associated with gas production by fermentive action of the bacteria. So you can see swollen reddish black, foul smelling due to anaerobes tissue with crepitus gas. How do we manage? So about the some often we do clinical diagnosis, and even without offering diagnostics, we go for the treatment. But for the sake of skin and soft tissue infection, we offer, if patient present with fever, as usual, we do blood cultures. But often even less than 10% of blood cultures become positive for cellulitis and other infection. Maybe necrotizing fasciitis, blood culture positivity may be high, maybe 30 to 40% high. But other instances, we don't offer. For the patient comes with simple abscess, we don't do a blood culture. But we do hematological parameters like the white blood cells with differential count, which indicates polymononuclear leukocytosis, indicates high neutrophil count. Unless if it is TB, maybe lymphocyte count be high. So other thing is, if we offer incision and drainage, that is for the abscess, we do gram stain and culture. But for the cellulitis, we don't often do SOBI. But if patient having blisters, we try to catch blister fluid, then do the gram stain and culture. That's how it goes. And later on, if depending on this condition, we often offer ultrasound or maybe CT or MRI for emergent studies. It requires, depending on the condition, cellulitis, maybe with 10 to 14 days of antibiotic, even IV, we can convert into oral. We'll discuss further. Here about the gram stain and culture of pus from carbuncle and abscesses are recommended, but treatment without these studies is reasonable. In typical cases, clinical diagnosis will enough. Same, gram stain and culture of pus from inflamed epidermolysis are not recommended, so no need. IND recommended treatment of inflamed epidermolysis, carbuncle abscess, and large furuncle large. Right? Here you can see parole and non-parole. Depending on that, severe, moderate, mild, we can guide the therapy. We'll discuss further. Parole, severe, we do incision and drainage. Otherwise, IND only, mild IND only, clean and yes. Empirical treatment is there, empiric treatment. Here you can, if it is defined MRSA, if it is MSSA, we go. If it is MRSA, we go vancomycin. Likewise, you can appreciate this. Further, the decision to administer antibiotic directed against Staph aureus as an adjacent to IND should be made based upon presence or absence of systemic inflammatory response. So here, mainly managerial aspects are discussed here. Just read, but it's case by case, okay? So for the antibiotic active against MRS is recommended for patients with carbuncle abscess who have failed initial antibiotic treatment or have marked impaired host defense or in patient with SIRS and hypertension, CDFO. It depends, okay? So you can see chart. Impetigo, what are the best? MRS, MSSA, SSTI, skin and soft tissue infection. MRSA, SSTI. What are the vancomycin, linezolid, even if it is susceptible, clindamycin, daptomycin, it's not available, captopril not available. Cotrim we can give, trimethoprim, salmeterol, doxycycline also available, likewise. Non-purulent SSTI, streptococcal skin, often it's penicillin. Standard dose for antimicrobial agents active against multi-drug resistant organisms. We may offer vancomycin, colistin, linezolid, maybe we combine. It depends, okay. So what is appropriate for evaluation and treatment of erysipelas and cellulitis? Now we are going further. Culture of blood or cutaneous aspirates, biopsies, that's another one. Histopathology or SOPs are not routinely recommended. C, that's why I said. Cultures of blood are recommended and cultures and microscopic examination of cutaneous aspirate biopsies, so SOPs should be considered a patient with malignancy on chemotherapy, neutropenics, severe cell-mediated immunodeficiency, immersion injuries, and animal bites only. So typical cases of cellulitis without systemic signs should be receive antimicrobial agents for streptococcal. For cellulitis with systemic sign of infection, we have to suspect MSSA and go for systemic antibiotics. Likewise, there are different conditions are discussed. In severely compromised patients, broad-spectrum antimicrobials like vancomycin with plus either piperacillin, tazobactam, or imipenem or meropenem is recommended. It depends. Okay. These are extracted from IDSA guideline. So it's maybe beyond in your level, but you get what are the conditions, how often we diagnose, what is the treatment. That's all what you know, and duration of treatment and how to monitor treatment like other infectious diseases. Here we can do CRP and every other day CRP, not every other day. I mean, first we do a baseline, then in 48 hours we do while we have started the antibiotic and we are monitoring the response, then no need to do another 48 hours, but we can monitor the response, clinical response, and do. But later on, it's better to give 10 to 14 days. Prolonged antibiotic is not as much as like osteomyelitis, or septic arthritis, or melioidosis, or tuberculosis, or infective endocarditis. But here we have to give minimum 10 to 14 days. Like, so you can just read. I sake of the completion of the lecture, I put those things, but don't confuse much. Just read through. Anti-inflammatory drugs. It depends. Okay. Corticosteroids, unless non-diabetics, we can prescribe. Recurrent cellulitis is a different entity. Maybe patients with elephantiasis following what is this? Filariasis that can develop. Patients with lymphadenitis and prolonged chronic lymphatic obstruction, they may prone to develop maybe filariasis. So they prone to develop recurrent cellulitis. So as that predisposing conditions, we offer prophylactic antibiotics. Another place like surgical prophylaxis, here patients who have in recurrent cellulitis we offer, but it's a specific specialized guided therapy. Okay. So we often give penicillin or erythromycin or benzathine penicillin IM intramuscular every 2 to 4 weeks. Like who has had 3 to 4 episodes of cellulitis per year. That's how we often treat. Management of surgical site infection. It's another one. It's a suture removal plus incision and drainage should be performed for surgical site infection. That's how it goes. And depending on that condition, we monitor, like then it should appear as trauma or wound infection. Mind you, wound infection also different entity, but maybe antibiotic required, maybe not. I'm not telling about surgical site infection, about the wound infection. Often wound infection, Sobin also, I think it should be done properly, but even doing the proper way of Sobin, often it gives the colonizers, so even it gives the not proper, we are not taking from the proper wound edge, because even once we visualize, observing area is the one, not the place where infection is not happening. So we have to go deeper. So often advice is to get deep tissues. So it's advisable when patient is offered to incision or clean and dressing, C&D, or wound debridement. On that particular moment, surgeon can take deep tissues and send for the culture in sterile container, same as wounds or pus. Then we do gram stain by chopping those things and do the culture as well. So it gives a good etiological diagnosis. Rather doing Sobin, it often we may get colonizers, not the real pathogens. Even it comes with MRS, always patients who's having a wound, patient looks well, it's advisable to do a CRP. If CRP is less than 5 or around 10, maybe normal, we don't offer antibiotics. Its local treatment will be enough. Here what I discussed earlier, necrotizing fasciitis. So it is surgical emergency. At the same time, we offer broad spectrum antibiotic empirically, vancomycin or linezolid. So cover MRSA plus gram negatives with anaerobes, piperacillin tazobactam, or carbapenem plus baby vancomycin with ceftriaxone and metronidazole. So it gives broad cover. Vancomycin, gram positive, gram negatives, gram negatives, piperacillin tazobactam or imipenem or meropenem or even ceftriaxone. So once combined with metronidazole, it's anaerobic cover. It's a broad cover. Maybe we cover with clindamycin, vanco plus, clinda plus, piperacillin. That's how it goes. Other penicillin plus clindamycin is recommended for treatment of documented group A streptococcal necrotizing fasciitis. It's a common condition. And group A, which gives necrotizing fasciitis. Here our main is penicillin. It's a penicillin sensitive. You may think why it is we are giving two antibiotics, because we know isolate is there. Earlier I said about empiric. Here targeted therapy. So we have taken pus or necrotizing fasciitis. We have taken tissue as well as we did a blood culture, but all became positive for group A. Now we know more often group A is sensitive to susceptible to penicillin. If we don't want to give higher antibiotics, we can kill him with pista. No need of shotgun no further. But why are adding clindamycin? Think here our main aim is group A streptococcal pathogenesis is mainly by production of toxins. So clindamycin one which act on protein synthase inhibitor. So clindamycin inhibit toxins are most higher proteins. Protein synthesis inhibited means toxin production is inhibited. So adding that penicillin will kill. Meanwhile, there are survived streptococcus are there. Maybe it takes time to kill those. So meanwhile, once we are giving additional cover and obstructing their or inhibiting their protein synthesis, ultimately we can get a good prognosis or good outcome. Otherwise, patient may undergo sepsis. That's why we are combining here in one combination. So mixed infection, I said, pyomyositis. What I said earlier, MRI or CT, culture of blood and abscess material should be obtained. So vancomycin for initial empiric therapy. Then we add, depending on that particular matter, we may add. Even if it is MSSC, we can step down to fluoxetine. Early drainage of purulent material should be performed. That's source reduction. It's therapeutic as well as diagnostic, because pyomyositis abscess, we often do deep maybe incision and drain or ultrasound guided aspiration, because antibiotic won't reach there. So once source is reduced, we can go for diagnosis as well as this focus of infection is removed. So curability or outcome is high, prognosis is good. Then repeated imaging should be performed in patient with one-way persistent bacteria to identify undrained focus of infection, as well as once we have drained the pus, repeat ultrasound scan is almost advised. If it depends, okay, anyway, but it's better to do one and assess the status. So is there any residual volume is there? That's why. Maybe patient is not responding, then we do repeat scan to assess is it developing further ongoing. Maybe focus has not removed properly. So then we have to go for open. It's depend on the surgical team's decision. Okay. So it like here, antibiotics should be administered IV initially. Bacteria cleared promptly and there is no evidence of endocarditis or metastatic abscess. Then 3-week therapy. If it is having endocarditis, it differs, maybe 6 weeks. Clostridium, gas gangrene, or myonecrosis. Urgent surgical exploration. Then broad spectrum, vancomycin, either piptas, piperacillin tazobactam, MP sulbactam or carbapenem is there. Definitive antimicrobial therapy with penicillin and clindamycin is recommended. Hyperbaric oxygen therapy is not recommended nowadays because anaerobes, while adding high pressured oxygen, we think Clostridia will kill, but nowadays we often not reluctant, we are not doing. What is the role of preventive antimicrobial therapy to prevent infection for dog or cat bites? Preemptive early antimicrobial therapy for 3 to 5 days is recommended. Patients with immunocompromised, immunocompetent, we are not offering. Spleen therapeutically or traumatically removed, splenectomy done. Have advanced liver disease, have pre-existing no resultant edema of the affected area. Then we think there is ongoing infection. Have moderate to severe injuries, especially to the hand or face, high blood supply in area. Have injuries that may be penetrate the periosteum or joint capsule, which they are more prone to develop osteomyelitis or septic arthritis. Post-exposure prophylaxis for rabies may be indicated. It depends, okay? But we have to think always. Then, treatment for animal bite wounds. Amoxicillin clavulanate or coamoxicillin will be enough, but it depends. Tetanus toxoid, if patient vaccination within 10 years, okay. Without toxoid vaccination within 10 years, we have to give. We give the tetanus only mainly. Primary wound closure appropriate for animal bite wounds. Often our advice is not to do primary wound closure. It's not recommended for wounds. There are in the phase which should be managed with copious irrigations. Likewise, we do. Otherwise, we often not recommend in early wound closure. Again, you can see what I said. Define treatment, necrotizing fasciitis, empiric treatment, surgical and empiric. Likewise, if you know this with the diagnosis, clinical condition, that will be fine. Thank you.